And Jake, I will hand over to you.
Fantastic. Thank you very much. First of all, thanks very much, Stacey, for having me and allowing me the opportunity to have a chat with you all. So today I'm going to be talking about exercise physiology, and MND, and what that all means together. So as Stacey mentioned, my name is Jake O'Brien, and as a quick introduction, I'm an accredited exercise physiologist. I also hold a graduate certificate in rehabilitation, majoring in occupational therapy. But in saying that, I'd never call myself an occupational therapist because I'm not. And I work as an exercise physiologist and also one of the team leaders at Better Rehab. So Better Rehab is a registered national NDIS provider. So we deliver services nationally. We have offices, quite a few down in Southeast Queensland here, down to the Gold Coast, through New South Wales, Victoria, and also over in Perth now. And we're part of an MDT allied health team. So we have multidisciplinary therapy. So we look at occupational therapy, speech pathology, physiotherapy, exercise physiology, and we also have allied health assistants with us as well, which is a fantastic setup because we have many different practitioners of many different disciplines, but also with many different interests and specialties as well. So working together, which we often do, can be a really exciting and a really valuable and productive resource for all of us. So some of the things that we're going to try to cover today, and hopefully I'll be able to answer some of these questions, is first of all, what is exercise physiology? It's a bit of a newer discipline to the allied health team, so I'll run through that briefly. Where does it fit into the management and the treatment of MND? What does the most current research say about exercise and MND? Because that's quite a contentious topic. Where does exercise physiology fit in with the MND care team and those multidisciplines? And what this means for us as practitioners, participants, patients, and the care team generally. I'll also point out, I'm going to try not to cover too much of what we had Nikki and Adina cover do a presentation on exercise and physiotherapy. So I'll try not to cover too much more of the information that they've already run through, but I recommend if you do have some interest and more questions in this field, that's a really great presentation to refer back to and have a look at as well. So first of all, exercise physiology. So what is it and why do we do it? So our why is all about looking to improve quality of life, increase functional capacity, reduce risk of chronic conditions and disability, and to be able to empower our patients to try to take control of their condition as well. And the way that we do this is through health and physical activity education, clinical exercise prescriptions, psychosocial health management, and also lifestyle modification and behavior change. So these are things that we spend a minimum of 4 years, 5 years if you're myself and go on exchange and then travel for a while. But we learn all these skills at university, and we try to put all of these in practice when we start to do any of the duties that we're called upon throughout our work. And as I mentioned, I work in the NDIS space primarily. So our scope can quite vary between different conditions that we might be looking at, whether that be disability, neurological, cardiac, metabolic, or mental health. And so some of the things that we look at in terms of outcomes from an EP perspective, and I'll refer to exercise physiology as EP quite a lot throughout the presentation, by the way. It rolls off my tongue by now. So the outcomes that we're looking to find is to maintain a quality of life, to help or maintain strength in the entire body, but in particular in unaffected muscles, depending on what stage of progression we're at with the MND. Maintain flexibility and range of motion, pain management, and also mental health management. which can sometimes be slightly overlooked, but obviously this can be a devastating diagnosis at times, and the progression of the condition can always raise some mental health and psychological challenges. And I think that's an important thing to address, regardless of what therapy and what modality we're putting in place. So why and when would we use exercise physiology? I'm probably going to give quite a vague answer about this because it's all about the participant. It should always be patient specific and it should be individualized. So some of the factors that we might look at when we're addressing whether exercise physiology is the right fit and when it might come into this treatment process is around consideration of what tasks are important to the participant and the patient, current symptoms, the stage of the disease, rate of progression, and also exercise tolerance, or even exercise history. So all of those questions need to be addressed or looked at to be able to determine what we are specialized in, which is working out exercise prescription that has a frequency and intensity, the time and the type of exercise or movement therapy that's being put in place. And all of those factors are variable and they're all specific. So to find the right amount of and the appropriate amount of load or time or resistance that we're working with, we have to consider all of the factors above. And also as part of this, we want to ensure that patients maintain self-efficacy and be an active part of their treatment. So this is quite important as well to us generally in exercise physiology, but in particular in the M&D space, is that we want to make sure that we can still have the participant taking control of some of that treatment and being an active part of that therapy, which is very important, rather than implementing some level of treatment and just allowing them to be a passenger. So one of the big things that I wanted to address first of all was around fatigue. Fatigue is one of the most addressed concerns when implementing exercise as a treatment. And it's one of the reasons why exercise for quite a long time had the consideration that it may not be helpful or useful for management in M&D, and that it may have detrimental effects or adverse effects. So there was a study looking at specifically with M&D that was done in the UK, I believe, looking around fatigue, and it found these two forms of fatigue which were reported around this whole body tiredness, and also the alternative of motor weakness caused by exertion and partially relieved by rest. So this whole body tiredness is this fatigue, this almost flu-like rest or fatigue of the body. And then we have this motor weakness, which might be similar to something of lifting some weights, doing a heap of bicep curls, and at some point the arm can no longer lift the weight. And then we have that motor neuron fatigue. And then as a result, we can't lift anymore. And then with rest, we can have some more, some recovery and output. So in terms of prescription, those two things need to be monitored, but can be interpreted very differently. So that's important when we're looking at fatigue when implementing exercise prescription. Fatigue is also associated with poor mental health, reduced quality of life, and functional status. So this is really important as well, because these were some of the outcomes that I mentioned earlier we would be looking at trying to improve. So if we come to the conclusion of exercise equaling fatigue, and fatigue equaling poor mental health, reduced quality of life, and functional status, it's pretty easy to kind of draw that connection between reduction in these outcomes and exercise. But as we'll go through with a little bit of some of the research that's come out now, to ask the question, does exercise necessarily equal fatigue? So I'm going to briefly touch on a few articles that are recent research that have come out. But I wanted to put out the disclaimer, and I know that Adina and Nikki, when they delivered their presentation, touched on this, is that the current research is scarce and it's plagued with issues around reliability and validity. The sample sizes are small and there's quite a lot of dropout within these sample sizes, which makes them considered to be low quality. Long-term follow-up is rarely available as well. And as a result of all these things, these are not necessarily high quality studies. So unfortunately, with the nature of the subjects that need to go through these studies, from an ethical point of view, from the progression of the condition, it makes it very hard to have quality evidence. So I'm going to present some of the evidence that we do have, and some of the conclusions that have been drawn from that. So this is our first one done by Meng and colleagues, and this is quite recent that this was conducted. So it was a meta-analysis or a systematic review. So what they did is they looked at a whole host of studies, and from that put parameters in place to kind of get the studies that were trying to answer the question that they wanted answered, and that those studies were of a particular quality that deemed them to be eligible for review or somewhat reliable. So after they went through all of those studies, they found themselves with 7. And of those 7 studies, they were quite variable in what kind of exercise was being prescribed and what they found as well. So some of the modes of exercise is aerobic endurance. So exercise done with oxygen. You could probably think about walking, jogging, rowing, cycling. They're examples of aerobic endurance exercise. Strengthening exercise, which and endurance and resistance. So that's looking at body weight work, whether that might be squatting, sits to stands, exercise done under load. Then we have range of motion exercises, which is moving a limb through its range of motion at a joint, which can be done actively by a patient, or it can be done passively as well by a practitioner. And then stretching, which is a commonly prescribed form of exercise programming in MMD, which looks at somewhat a combination of range of motion and also low level resistance. So the equipment that was included in some of these trials were arm ergos, so arm pedal bikes, treadmills. They used weights, and then a number of other kind of resistance equipment, whether it be resistant bands or loaded resistance machines. So these are all, there is variable equipment that they have used in these studies, and not necessarily put things off limits or contraindicated any of this equipment. And the intensities that they looked at were low to moderate, and that was the majority of the studies and the majority of the studies that have been done. And then there was another study in there that did start to work towards that moderate to high level of exercise as well. And so the conclusions that were drawn, from this study were that exercise can be safe and beneficial for outcomes in patients with MND. As with most of the studies that we're going to have a look at, and out of the 7 studies that they found that they reviewed, is that further studies are required for best practice around prescription. So that's looking at what type of exercise is best, what volume is best, and how that be presented. So that's also still up for debate at the moment. Higher levels of fatigue were not associated to exercise in any of the studies that they looked at that actually measured fatigue. So that's a really important finding that they've reviewed there as well. And endurance and aerobic exercise was found to be more beneficial in terms of function than resistance training. The therapist should encourage patients to exercise, was their message at the end of the day. However, should closely monitor fatigue levels and any adverse effects from exercise prescription. So as we could imagine, we've seen out of these results that fatigue levels were not necessarily associated to exercise, and that there were no adverse effects, but we can probably tell by the quality of the studies, as well as the low subject numbers, that this is still something that they're concerned about in terms of fatigue levels and adverse effects due to exercise. And that's important to note. And as I mentioned before, limitations of these studies were small sample sizes. Some did not include medium and long-term follow-up as well. So the second study that's come out, which is quite important from an intervention point of view with exercise, was looking at the effectiveness of home-based and unsupervised exercise. So by unsupervised exercise, what they're referring to is participants doing an exercise prescription that has been professionally developed in their home with regular follow-up from a practitioner. But when they're performing this exercise, they're doing it unsupervised and of their own accord. So they looked at early stage participants, which in the previous study as well, they were looking at early stage participants, and most of the research in this space is done with early stage participants. They had 21 participants undergoing unsupervised exercise, and then 84 were going a normal course of treatment with a physio that led the exercise prescription. The intervention in this one was performing strength training, stretching, and also functional training. So varying across a few different modalities of exercise there again. And the prescription was developed by a practitioner for each individual. So as I mentioned, even in the unsupervised exercise group, the prescription was done by a practitioner, and it was individually based as well and patient-centered. And the duration of follow-up was 6 months in this case as well, for the majority of the studies that they looked at here. So what they found was that home-based exercise was found to be safe and feasible for patients in early stage MND. No adverse effects were reported, and no overwork-related weakness was found during muscle testing. And a really huge finding in this one was that respiratory function results were significantly higher in the unsupervised group as opposed to the supervised group. There was actually no deterioration found over that 6 months from the group that was performing unsupervised exercise. So they concluded that there may be benefits to that. I think the big things in this were that we found it safe and that it was feasible to have unsupervised exercise performed at home within the parameters of the therapist, as well as finding that respiratory function was actually maintained in some of the group that were performing exercise at home unsupervised. Once again, though, we have small sample sizes, and for ethical reasons, this study was not randomized. So participants were chosen into those particular groups as well, which doesn't make it as high a quality study as some others that are randomized. And then the final study that I just wanted to have a quick look at as well was reviewing exercise generally within the M&D space. And this was also, once again, looking at a number of different studies and collating all of the conclusions that they've come to and the therapies that they've put in place, and trying to draw conclusions from a number of studies there as well. So the mode of exercise that was chosen varied slightly again within these studies, but they were looking at resistance training and aerobic exercise. And some of the outcomes that they were looking at here as well were the functional scores. So how well can someone perform activities of daily life? They were looking at quality of life. Leg strength was also reviewed, fatigue levels. And my last one there was pain as well, which was seen in a few of those studies. And the follow-up varied, but throughout some of these studies that they looked at, primarily it was around that 6-month mark that they were reassessing. So the conclusions drawn in some of these studies. So the ones that looked at resistance training found that one study showed better functional scores and quality of life, and a smaller decline in lower limb strength. So it showed some positive results in that particular study, whilst the other showed greater functional and spasticity scores, but there were no significant difference between the group that was exercising and the group that was going through normal treatment protocol in terms of fatigue, pain, or quality of life in that particular study. So it does represent that these studies can be quite variable in their findings in the way that they're conducted, and that's likely due to the quality of the study and also the number of participants that are available. In the aerobic exercise studies that they looked at, they did find improvements in functional and fatigue scores, as well as a gait speed, distance, and stride length. So some more of those functional capacity movements. And that particular study there was looked at by using a treadmill as the modality. So although exercise has shown positive benefits to patients with MND, once again, further quality evidence is required. And that's the conclusion that the author came to. And they also concluded, however, that with the well-known benefits of mild to moderate exercise for human beings in general, and the lack of negative effects of exercise on MND patients, that appropriately prescribed exercise should be a recommended treatment modality. So that's an interesting point as well. We do know that mild to moderate exercise has a lot of benefits to us from a cardiovascular point of view, from a body function point of view, from a mental health point of view. And all of these benefits are still benefits, regardless of whether they're found in an apparently healthy population or an MND population. And therefore, without negative effects, that this should be a recommended treatment as well when viable. So that's what our studies say at the moment, and a few different angles that those studies were looking at. But once again, to reiterate, more studies needed to be done and more quality studies are needed for conclusions to be drawn. I briefly wanted to touch on the EP and Physio collaborative intervention. So this is something that has, between Physio and EP, there is some overlap. There's some unknown overlap between the general public as well. I've got my little meme that I made down in the corner: when exercise physiology and physiotherapy working together, is that we have better care and outcomes for MND patients. So the answer to, do we use physio or EP intervention? The answer is both. So initial assessments from multidisciplines allow for a higher level of care and monitoring, as well as the most appropriate and successful intervention. I will mention at this stage that the most important thing in choosing this care team and this MND team is to be able to look at a practitioner who has experience with MND or is aware about how to go about placing these interventions within the therapy. So that may say that an EP may be appropriate for this intervention, but may not have worked with MND participants before, and you might be better off with a physical therapist for exercise prescription that has, or vice versa. So EPs generally look to prescribe appropriate individual exercise prescriptions, lifestyle modification if relevant, address psychosocial factors, as well as mental health management, and work within pain management as well. And physical therapists assessing and monitor respiratory function, range of motion, which both EP and physio can work with range of motion. I just wanted to point out that range of motion passively is more into the space of physiotherapy than EP, as we are hands-off, and physical therapists work with hands-on on occasions as well, and that's part of their specialty. Management of contractions, exercise prescription again, and pain management. So there is a level of overlap there. And once again, I will stress that it's more about finding the right practitioner for you and the right practitioner for the role. And then in particular for us as the multidisciplinary team. So as I mentioned, we're pretty fortunate at Better Rehab to have a whole lot of us under the one umbrella here. And so a collaborative effort is something that we strived for, and what brings us greater outcomes and benefits to the participant. An assessment from speech pathology and occupational therapists are also recommended. They're able to prescribe assistive technologies and monitor progression to work out when those assistive technologies may come into play, and prep for the future there, as well as obviously their own niches and specialties within those disciplines. Other considerations may be allied health assistance. We know that the treatment process through MND can be a costly one. And for the example of exercise physiology, in which we can provide an exercise prescription, which can be reviewed from us regularly, or alternatively, we can start to maybe push out those review sessions, and we can enlist the help of an allied health assistant who can look at supervision, adherence, and performance of therapies such as home-based exercise prescriptions. So we commonly use our allied health assistants throughout our work and treatment of the patient, in which we can still prescribe and have that level of care, but we have those touch bases, which can be really handy, and at least in the NDIS space, can be very cost effective to be able to utilize allied health assistance as well. So now, what does this mean in terms of recommendations, or where we're at the moment with exercise physiology, and MND, as well as that MDT team? So the use of exercise as a treatment modality in patients with MND is supported within the available research. And that's very importantly within the available research. More research is needed, more quality research is needed. From what we can gather from the research that we have, is that adverse effects have not been recognized. In saying that, that's not recognized within professionally monitored and that low to moderate exercise, which is closely monitored by the care team and developed with the participant as well. And most of those studies, importantly, are done in early stage MND. As I mentioned, this needs to be patient focused as well, and it's highly individual and needs to be specific to the participant. And that exercise prescription should be developed with the input of the patient, the accredited exercise physiologist, the physiotherapist, and any other relevant parties of the care team as well. Correspondence and care coordination between practitioners is highly important in MND. That's what we strive for at Better Rehab, as well as working with other practitioners that are outside of our company as well, because that's highly important. And the general plan is to assess as early as possible, to monitor and review, and put in the right therapies and the right action plan for the specific individual throughout that timeline. Thank you very much. Kept it fairly brief for you today, but hopefully that answers some of the questions around exercise and MND, and also exercise physiology space. My contact details are obviously there as well. I'm more than happy to answer questions or refer information on as well. I also have the research that I've put throughout this presentation on a slide at the end of this this PowerPoint as well, which I'll bring up in a moment if you wanted to do some further reading. Otherwise, you can feel free to reach out to myself, and I'm happy to send through any of that research that I've been aware of or looking at throughout. Any questions at all? I might hand it back to you then, Stacey, if that's all right as well.
Sorry, let me just unmute myself first, and then I will unmute everyone else. Right, so if you can unmute yourself, then yeah, I can't unmute anyone else if they already muted themselves. So it doesn't look like I can do anything but ask you all to unmute yourselves. Do you need your screen still up here, Jake? I think you mentioned that you wanted to.
I'll put that still up, but otherwise, if anyone wants to refer back to that, that's the relevant resources and information. But maybe otherwise I'll stop the share screen and we can go to the.
Perfect. Now we can see everyone's faces again. Excellent.
Perfect.
All right. Well, look, I thank you for that. That was really interesting, and certainly I learned a lot around some concerns that we've always had about the impact of fatigue of exercise. That was really good to hear. I do have a number of questions, but before I take over the question time, let me just check who else wants to ask a question. Right, yep.
Jake, prior to any physical activity or exercise, if you take a painkiller or an anti-inflammatory and to reduce the pain to do that exercise, does that actually damage any of your muscles or during that period when you're not feeling any sort of pain?
Yeah, there's certainly outcomes within that. I mean, it's something that we monitor throughout exercise prescription, and certainly medications generally are a big part of that monitoring and understanding exactly how someone's feeling and the adaptations that may take place. In terms of anti-inflammatories, there's some research in the space of not exercising too soon prior to taking them. But again, that research is a bit hit and miss as well. I mean, it's a very vague answer, but it's very patient specific again. And that we can find that there is changes in terms of sensation, but that's part of that conversation that we can have. It depends on also what you're looking at in terms of an outcome. If we were looking at pain generally and we wanted to try to change pain levels, then that's something that we would have that conversation around during exercise, and we can use exercise to try to do that. And so, as you can imagine, having blurred results or perceptions around how something feels may change that outcome or change the perception of that outcome anyway. In terms of damage to a muscle, I don't believe that would be the case. It's more of the research that I've looked into is further around how the anti-inflammatory is metabolized and what that might mean for stomach ulcers and things like that, which I think is where some of that primary research has gone. But that's probably a good place for me to even sharpen up on some of that knowledge, Ray. So I'd be happy to look further into that. But as far as I know, within that vague answer that I just gave, it's looking at, Yeah, I
was just thinking in terms of a task that you might not normally do. You take a painkiller, that enables you to do the task. Then you feel tired at the end of the day and then you have a rest. But during that time while you're doing that task, like doing any sort of physical work or whatever, I just wanted to know if that did actually do any harm to your muscles during that period.
I mean, certainly you're right, Ray. So retrospectively would be certainly an important place to go with that as well. If we are doing exercise and then later on it puts you out of action for the next few days, then we're going to need to reassess the prescription and we're going to need to reassess the volume and what we're going through. But you're right, we might get some level of masking around symptoms or adverse effects to exercise if, we're using painkillers and then we're Superman for the period of time that we are performing that task. But does that give us kind of a clear idea about what the intervention we're putting in place and what outcome we're getting? So it can be an interesting one. If we think about it from even the terms of using something like a knee brace to get through exercise or taping, we're changing the input slightly in order to be able to perform that task successfully. We still get a result and an outcome at the end of the day from doing that. But we're more so changing the level of load that we're using. and we're changing the task, and it's possible to, take that brace off after doing the exercise and having adverse effects post exercise. So it's certainly something to monitor. But yeah, that would be certainly a conversation to have with the practitioner as well. We always have to disclose what medications we're taking, how often we're taking them, because that's always going to affect what's happening physiologically, which is what we're looking at doing, is having a physiological adaptation and change. So that's certainly part of a piece of that puzzle to give us the most information that we can. Yeah.
Okay.
All right. Any other questions?
Yeah, I got one. I still am on anti-inflammatories, and I still get a bit of pain, but I make myself walk a certain distance, and I still do me garden, although it's a lot smaller now. And I find when I get tired or start to come bother, I go and have a rest for a while and then resume. It's keep me going. If I hop on a machine that's hydraulic or working, that makes it easier. I can go longer, but weeding that, I can't do it for too long without a rest. Is that normal? Should I push myself a bit more?
Yeah. So, I mean, I think there's two important points in your question there, Sam. One of those around pain, and then the other around fatigue. So it sounds like from a fatigue point of view, we're looking at what we mentioned before in that neuron fatigue. So when we're using a muscle for a prolonged period of time, at some point it can't continue to that capacity, which we find in apparently healthy populations as well. And then we can have rest and relief and then continue with a task. Similar to what we would be doing in terms of an exercise intervention is about what does that mean after the event? Does that mean by doing a day's worth of gardening, do we spend the next 2 days in bed? Which would be something that we would be concerned about.
If I did a day gardening, I think I'd need to sleep for a week.
I feel that way sometimes too. But yeah, exactly. I mean, it's about managing that level of load and that level of intensity as well. We could look at these activities of daily life like we would look at an exercise prescription. What is the appropriate amount of stress to put on a body to get the ideal outcome? And that's actually an important point as well, Sam, is to be able to fit an exercise prescription in with someone's daily life activities as well. We don't want necessarily an exercise prescription to be done, and that means that you can't do the things that you would like gardening, due to fatigue. So that's an important balancing act. In terms of the pain question, that one's a lot more subjective, and I could probably talk to you about it all day, Sam. It's a bit of an interest of mine, but it's a fine line in terms of what we do with active therapies. And if we talk about maybe an apparently healthy population initially, we would use active therapies to kind of push the threshold slightly of where someone feels discomfort and pain. If we're talking about chronic pain, a little bit of pain is okay in that population, within reason, because it's part of the pain is like an alarm system. Yeah. It's not necessarily recognizing damage all of the time. They're two very different things, pain and damage. So again, it would be working with the practitioner to try to identify what is the right amount of stress, and what kind of pain are we working with and to what degree. But yeah, very vaguely, it's talking about, is there damage? Is there just pain? Is it low level pain and is it manageable? And does it improve if we were to work through that over time? But yeah, I'd be happy to talk more about that, Sam, at some point as well.
I would like that.
Yeah.
At times it really bugged me because sometimes the pain can be intense, and sometimes it's not so bad. I can tolerate it, but it's getting worse as time goes on. I guess that's the nature of the beast.
Can be, yeah. And context is always a very important part of that conversation as well. How we interpret what's going on and how the body is interpreting whatever the stimulus might be. But yeah, that's once again quite a individualized and patient specific question when we get into that depth as well, Sam.
Yeah.
Andrew, did you have a question? Sorry, Sam. Andrew, did you want to ask a question?
And there are studies that have indicated that in normal people, post-exercise muscle pain is associated with raised creatine kinase levels, which means muscle damage. But I mean, there are obviously other causes for pain in people with MND.
Yeah, so it's again comes back to finding what is the appropriate amount of stress and load on a body, which is essentially what we're doing with an exercise prescription. Is we're trying to create enough stress that we get some adaptation and change. But you're right, it's that balancing act of not going to the point of having a positive experience with that exercise prescription generally. So it can be a balancing act, and that was one of the things that is within the research that has drawn some of the conclusions prior, and again something that requires further research as well. Unfortunately, it's one of those things behind the curtain at the moment. Yeah.
I guess I'm trying to say that the saying "no pain, no gain" is probably not necessarily true.
No, it's yeah, an extremely simplified outlook on exercise prescription anyway. It works for some, I suppose. Some might work well under that mantra, but it's not necessarily something that I promote, especially not with everyone. Yeah.
All right. Any other questions? No?
Yeah, just a very mechanical question, far less important than the ones that have been on the table. NDIS, does it fund exercise physiology the same way as it does physio and OT? I have a vague recollection that you have to have a different pile of funding in your plan to get exercise physiology. Yeah,
so we're a little bit special in the sense that we have health and wellness, which is sometimes part of plans. So we can be funded out of that health and wellness bucket. However, we also have the capacity to come out of the same funding that's available for occupational therapy, speech, and physiotherapy as well. So it's not all the time people will have funding available in health and wellness, and therefore daily living is a bucket that we also come from for funding. So yeah, it can be, yeah.
Thanks.
No worries. We're also slightly cheaper as well, Keith. Bang for your buck there.
And that was going to be my question, Jake. How does the price compare with the NDIS rates for, excuse me, for OT and physio?
Yeah, so we're about, what are we? just under $30 cheaper. So we're at 167,
Okay.
and the value for OT, speech, and physio is 193.
Yep. Okay.
Yeah.
And so, if you don't mind, I'll ask my next question because it really does lead on from what Keith just said.
So
If we were supporting a person at a planned review meeting, how would we best justify the need for exercise physiology funding in a plan?
yeah, it can be a tough one. Are you talking about who's promoting it? Would the participant be looking at involving exercise physiology, or would you be advocating for exercise physiology?
Well, I guess so. Let me backtrack on a question that I would have asked first. Is what would a person that hasn't seen this presentation, when would they become aware of exercise physiology? What would they expect the referral pathway to look like?
Yeah, so I guess in terms of outcomes and what we want to achieve and their goals can be a really good place to start. Working in that functional capacity space and thinking about, well, what's needed for someone to achieve, always looking at their NDIS goals, for example. And then what kind of therapy would be relevant to get to that place if we took the stepping stones back to a practitioner. Again, it's looking at finding the right practitioner, whether that be in EP, physio, or the combination across those, to be patient specific. But it would be, I would probably look at the outcomes and the goals and where we were going with that space, but also around the participant and finding out exactly what they see should be implemented. So EPs spend quite a lot of time around behavior modification and lifestyle change. Again, with psychosocial factors and mental health as well. Something that's quite driven into us. And if there are factors in the participant's care that may need to be addressed, then that might be a call for exercise physiology. And again, there's those overlap between exercise prescription and physiotherapy, as well as exercise physiology. And physical therapy, exercise prescription is our bread and butter in what we do. So if someone has an exercise history or would like to know that they can still do some level of exercise regardless of condition, then that's very much our specialty.
Okay, so I guess what I take from that is if it was an initial plan, and the goals would generally be around that maintaining independence, and therefore would probably be better off going for physio funding because it's that higher rate and you can still use it for exercise physiology. And then subsequent plans, there would be recommendations from the treating professionals anyway.
Yeah, I mean, one of the benefits that we have being in a multidisciplinary kind of space is by going through those assessments, and that's when that can be flagged. So we very commonly will have a physio go to an initial assessment and say, this is more within the scope of an exercise physiologist, or this is more within the scope of Jake, for example, and vice versa. If we turn up at an appointment, do an initial assessment, then we can say, well, this is a bit more out of my scope. I think the person that would be better off treating this participant would be this particular physio that I work with here, or someone maybe outside of our company if we find that would be more suited as well. So it's one of the reasons that we think that a multidisciplinary kind of assessment is very relevant, because with the progression of the condition, it can change quite quickly. So we want to be able to have the right person at the right time and to be able to monitor and be able to recognize when a particular practitioner's therapy might be useful or relevant.
Okay. So I guess my next question is really around the fact that most of the people, or a number of people joining us today, would be funded through My Aged Care, and obviously we all recognise that My Aged Care is significantly less funding than NDIS most often. So therefore, allocation of funds for therapies is often more difficult to achieve. You mentioned about an exercise physiologist potentially prescribing an exercise program and then reviewing that, what sort of period of time would you think would be necessary so that we can look at how we maximize the access to a specialist therapist, but also not obviously spend funds that really aren't there?
Yeah, I think once again, it would be about the participant and the patient. What I would be looking for is what still gives us that gold standard outcome, what will give us the best outcomes, and would that be achieved with me seeing someone weekly, or could I get the same quality outcome and the highest level of outcome by me seeing them every month and having an allied health assistant going for those other 3 weeks of that month as well? And if that's going to be as good an outcome and save them money, then that's going to be the option that we're going to take. Ideally, I like to think about it as walking into that assessment and saying, all right, well, what's the best level of care that I can offer this person? And then from there, if that's not viable from a funding point of view, we start to work out, well, what are the options that are going to be viable that are going to give us as close to that gold standard as we possibly can. I think we're doing a disservice to our participants if we walk in there trying to bend off the bat to potential funding or whatever it may be. We want to still be able to put everything on the table so that the participant is aware about what may give us the best outcomes, and then we can start to work towards, what is our best outcome with the most viable plan of attack.
Yeah, that makes sense. All right, thank you. Any other questions? No? All right, well then, thank you again, Jake, for your time and your presentation and sharing your expertise. And thank you to Better Rehab for allowing you to join us today. We really, really appreciate it.
No worries. Thank you very much. And thanks for having me. It's been a real pleasure, and you guys are doing a fantastic job by allowing us to come in here on this platform and speak a bit of our knowledge as well. And thanks everyone else for having me and tuning in and giving me a bit of your time. Really appreciate it.